Hello and welcome to the Innovation Institute. Today you will be hearing a webinar from Dr. Pam Smith, a physician, master of public health, and author of the book, What You Must Know About Women's Hormones. Today you will learn all about women's hormones in patients in all stages of life. Dr. Smith breaks down hormone imbalances and how they play into PCOS, menopause, osteoporosis, PCOS, and more. Stay tuned after the webinar about our final discussion in this series and ways to connect with us. You can also visit previous webinars via our website. Dr. Smith's future webinars include weight loss, thyroid, and immune health. So make sure you sign up for those and stay tuned after the presentation. Thank you and enjoy.
Hello, everybody. Today we're going to examine looking at what you must know about women's hormones. Some of the references are on the slides. Some are in my book on women's hormones, and some are in my book on memory loss and how you can stop it. So there's a myriad of references for today. Menopause is the best time in a woman's life if her hormones are balanced. So we're going to focus on perimenopause and menopause. And since I'm a menopausal woman, I will definitely tell you that this is the best time in her life because the hormones are not flexing. They're the same all the time. And that's wonderful because there's no ups and downs. The hormonal response is unique to each person as her fingerprints. So this is very important to stress to your patients. It should not be considered without a thorough understanding of how the hormones work in the body. So I do spend time explaining to my patients about hormones. Normal menopause is ages 35 to 55, but many women have symptoms 5, 10, or 15 years before they go through menopause. So yes, they could be age 30 and have perimenopausal symptoms. Women who cycle after the age of 55 on their own without any hormonal manipulation do have an increased risk in developing breast cancer. So for those patients, we do look at estrogen breakdown sooner than later. It's important to define synthetic versus natural. Our patients always think that synthetic means it's a chemical and natural means it's from a plant, etc. And yes, hormones are from soy or yams, but honestly, that's not the definition of synthetic versus natural. Natural hormones are the same chemical structures God gave you to begin with. Synthetic hormones are not the same chemical structures. So they waste energy, they give incomplete messages to the cell, and they don't balance the other hormones. Why do we consider hormone replacement? Certainly, relief of symptoms has a lot to do with it, but also prevention of memory loss. There's enough in the medical literature now that we could spend an entire 4 hours discussing this subject. The same thing with heart health. There's so many things to look at. We could spend 4 hours on hormones in the heart. In fact, just before I taped this, seminar, there was an article that came out from the journal Circulation, and it truly very interesting. Heart health, hormones, very, very important. Also, we consider hormone replacement for bone production, growth, and repair. These are the hormones that regulate growth and repair. Sometimes we don't think about insulin that way, but it is. Growth hormone, testosterone, estrogens, and DHEA. When we look at surgery, I always have my patients stop their vitamins and nutrients about 7 to 10 days before surgery, resume them 4 or 5 days after. That's not true of hormones because these are hormones of repair. I have the patients take them right up to surgery and start them back right after surgery. It's amazing. Our patients do so much better, and their surgeons are surprised how quickly they heal. There's a lot of symptoms of menopause. It's not just hot flashes and night sweats, vaginal dryness, anxiety, mood swings, irritability, insomnia, depression, loss of sexual interest, hair growth on face, painful intercourse, panic attacks and anxiety, weird dreams. even urinary tract infections, because both progesterone and estrogen help innervate the bladder, vaginal itching, lower back pain, bloating, gas, and indigestion. And yes, bone loss. Estrogen maintains bone, progesterone builds it, testosterone builds it, adds the strength of bone. DHEA does all of the above, and cortisol. The patient stays stressed, they actually break down bone. Other symptoms of menopause: aching ankles, knees, wrist, shoulders, and heels. Hair loss is a big one. A lot of patients will seek care from us because of hair loss. Certainly, hair loss can be due to progesterone not being adequate, can be due to biotin being low, hypo or hyperthyroidism. There's a lot of reasons for hair loss, but it's a major symptom for patients. Frequent urination, snoring, sore breast, palpitations, varicose veins, urinary leakage when the patient laughs, coughs, or sneezes, dizzy spells, skin feeling crawly, migraine headaches, weight gain. The average patient gains 20 pounds at menopause and memory lapses. The memory just does not appear to be as sharp. I actually have all of these printed out as a handout, and I have my patients circle which symptoms they have, and then I put it in my electronic medical records. This way, I have a permanent record of the symptoms of perimenopause and menopause. Sometimes women get vaginal dryness before they go through menopause. So I like to use E3 estrogen estriol, and I have it compounded. I use 1 to 2 milligrams. I usually start with 1 milligram. And I like to use the cream because I get more absorption into the vaginal vault and a better layering. So this is how I usually prescribe it. Estriol 1 milligram as a vaginal cream, nightly for 2 weeks, Monday, Thursday for 2 weeks, and then PRN. It does matter what bases you put it in. I usually put it in 60% Versa base, VERSA base, and the other 40% is Mucilox, MUCOLOX. Mucilox is designed for mucous membranes to help with better absorption. And you can start this before menopause because estriol is a weaker estrogen. Estrogen does have literally 400 functions in the body, 400. It stimulates the production of choline acetyltransferase, an enzyme which prevents Alzheimer's disease. It increases metabolic rate, improves insulin sensitivity, regulates body temperature, helps prevent muscle damage, helps maintain muscle, it improves sleep, reduces the risk of cataracts, glaucoma, and macular degeneration. There's estrogen receptors all over the body, not just the obvious locations. So yes, there's estrogen receptors in the eyes. There's even estrogen receptors in the colon. So estrogen replacement helps prevent colon cancer. Estrogen does maintain the elasticity of the artery. It dilates small arteries, increases blood flow, and inhibits platelet stickiness. It even decreases the accumulation of plaque on the arteries. The only other thing known to do this is pomegranate juice. So I do drink 2 to 4 ounces of pomegranate juice every single day. It can decrease the accumulation and even reverse some of the plaquing. And studies initially were done on women. Now there's studies for men with the same great advantage of pomegranate juice. But when it comes to estrogen, it does decrease the accumulation of plaque on the arteries. It enhances magnesium uptake and utilization. It maintains the amount of collagen in the skin. In fact, you can actually look at people and you can determine if they're hormonally balanced or not by looking at their skin. Estrogen lowers blood pressure. It decreases LDL and prevents oxidation. It helps maintain memory, increases reasoning and new ideas. It helps with fine motor skills, increases the water content of the skin, and its thickness and softness. It enhances the production of nerve growth factor, and it even has a positive effects on the motions. Estrogen increases HDL, and it reduces the overall risk of heart disease by 40 to 50%. It decreases lipoprotein a major risk factor for heart disease. Estrogen acts as a natural calcium channel blocker to keep the arteries open. It enhances energy, mood, concentration, and it also increases sexual interest, reduces wrinkling, and lowers homocysteine. Homocysteine levels are elevated. The patient has an increased risk in heart disease, stroke, bone loss, breast cancer, and cognitive decline. So I do measure homocysteine levels in every single patient. About 50% of the world's population has a problem with methylation, and homocysteine is part of that pathway. I do. Fortunately, I actually found out about natural hormones 29 years ago. And so I've been on progesterone first and then later estrogen, etc. But 29 years ago, I did find out I had high homocysteine. So I've been taking methotetrahydrofolate for 29 years. So my homocysteine has been normal that long. It's fabulous because you can really change and help people's genetic history. In my personal family, there is no diabetes whatsoever. There is an increased risk in heart disease, and yes, we do have breast cancer. So having a normal homocysteine decreases my risk factors. Thank goodness that estrogen decreases wrinkling. It helps prevent tooth loss, and it aids in the formation of neurotransmitters like serotonin, the happy neurotransmitter. Many women are estrogen dominant. They have estrogen excess. PMS, PCOS, perimenopause, menopause, PMDD, all tend to be estrogen dominant states. And patients can have cervical dysplasia. They can have depression with anxiety or agitation. Other symptoms of estrogen dominance, there is an increased risk of uterine and breast cancer, weight gain around the abdomen, hips, and thigh, water retention, headaches, poor sleep, panic attacks, swollen breast. I hope you're thinking of your patients as we go through all of this. If she's still cycling, heavy periods, an increased risk in some autoimmune diseases, such as lupus and rheumatoid arthritis, hypothyroidism, fatigue, irritability, mood swings, fibroids, bloating. How can a patient have too much estrogen? The number one reason now, honestly, is people being prescribed too much estrogen. It's really important to look at things physiologically. A woman at the age of 25, when she has her peak hormonal function, preluteally, when she makes the most estrogen, she makes estradiol 365 micrograms. Micrograms. Commonly, people prescribe too much. The patient then becomes out of balance. Also, poor elimination of estrogen. Most of estrogen is eliminated through the liver, but new studies are showing some estrogen in the body is eliminated through the GI tract. So you want the liver to be functioning optimally along with the gut. Lack of exercise can cause estrogen dominance. A diet low in grains and fiber. This one is becoming more common as well as people avoid gluten. And some patients have not discovered other grains such as quinoa. There's environmental estrogens. I'm actually going to stop here and take a drink. Unfortunately, in my iced tea here does happen to be, it is in plastic. Plastic is an environmental estrogen. We talked about synthetic estrogen. It's not the same chemical structure, but believe it or not, worldwide, the number one estrogen still prescribed is Premarin. It is a synthetic estrogen. Natural estrogens, again, the same chemical structure. They help to protect against endothelial dysfunction by increasing endothelial nitric oxide. There's still a lot of naysayers out there thinking it doesn't matter if it's natural or not, but it does. Endothelial nitric oxide synthase is a crucial enzyme involved in the production of nitric oxide in endothelial cells. Studies showed that compared to natural estrogen, gene transcription of endothelial nitric oxide synthase was 30 to 50% lower in response to equine estrogens. So, another reason we want to use bioidentical hormones. Women make three estrogens. And I love the fact in medicine that things come from a Latin derivation. It makes it so easy to explain to my patients. E1 estrone 1, E2 estradiol di, E3 estriol tri. Then my patients get it. E1 is the main estrogen the body makes postmenopausally. High levels, many researchers believe, increase a woman's risk of breast cancer. So we do not replace E1. Very early on, some prescribers gave all three estrogens. As science has progressed, we've now learned that we don't need to replace E1. We give E2 and E3, otherwise known as biased. Estradiol, it is really the 400 functions. Estradiol is an antioxidant. It also helps with all the things we've discussed and the absorption of calcium, magnesium, and zinc. Results of a trial from 2020. Estradiol has a direct effect in reducing arteriosclerosis by decreasing cholesterol accumulation in the arterial walls. And then there's E3. It is 80 times weaker than estradiol, so it has a lesser stimulatory effect. Considerable evidence exists to show that it protects against breast cancer. Some of my patients say, oh, this is new information. My doctor has never heard of this. Actually, estriol was first published in 1924 in the journal JAMA. Isn't that amazing? Almost 100 years ago, we have known about estriol. E3 is being used in breast cancer patients experimentally. It is weaker, so it doesn't have the same bone, heart, or brain protection of estradiol. What does E3 do in the body? It's the estrogen that increases during pregnancy. It benefits the vaginal lining. It blocks E1 by occupying the estrogen receptor sites on the cells of the breast. It controls symptoms of menopause. It decreases LDL, increases HDL. It helps reduce pathogenic bacteria, restores the proper pH of the vaginal vault, which helps prevent urinary tract infections. And E3 helps the GI tract maintain a favorable environment for the growth of lactobacilli. Estrogen receptor sites are important to look at. Estrogen has two main receptors that bind it in the body: estrogen receptor alpha and estrogen receptor beta. Alpha increases undesirable growth in reproductive tissues. Beta decreases cell growth, and it helps prevent breast cancer development. It promotes beneficial estrogenic effects on the skin, bone, brain, and other tissues. So when we choose estrogens to give, remember that E2 equally activates estrogen receptors alpha and beta. E1 activates estrogen receptor alpha selectively in a 5-to-1 ratio. This increases cell proliferation, and again, a reason we don't prescribe E1. E3 binds preferentially to estrogen receptor sites beta in a 3-to-1 ratio, which may be the reason it helps prevent breast cancer. Siberian rhubarb has been shown to activate estrogen receptor beta to a greater extent than alpha as well. After menopause, the metabolization of estrogen can change. So if you've measured her hormonal balance before and her breakdown metabolization of estrogen before menopause, then you will need to go back and remeasure it again. Estrogen metabolization tests are urine tests, and they look at the breakdown products. There's two major competing pathways, the 2-hydroxyestrone and the 16, and the minor pathway, the 4-hydroxy. The 2 is what we lovingly call the good estrogen. It does not stimulate cell growth. It blocks the action of stronger estrogen products that may be carcinogenic. And the 2-hydroxy is protective against cancer when it's methylated, and you look at the COMT pathway. The ratio of 2-methoxy to 2-hydroxyestrone can be measured in the urine, and it is a good example of methylation. Another way to look at methylation is homocysteine. And now, of course, there's a whole methylation test that you can do by looking at methylation and then farther down in the pathway at transsulfuration. Low ratios of 2 to 16 hydroxyestrogen are associated with an increased risk of her developing lupus. So factors that support methylation, what helps the 2-hydroxy and methoxy pathways, SAMe, methionine, B2, B6, B12, folic acid as methotetrahydrofolate, that's what I take twice a day, trimethylglycine, and even reducing catecholamine production by decreasing stress supports methylation. The 16-hydroxy pathway patients need a little bit of to maintain bone structure. Too much breakdown into this pathway does increase her risk of breast cancer. High levels are associated also with obesity, hypothyroidism, pesticide toxicity, such as organochlorines, omega-6 fatty acid excess, and inflammatory cytokines. The 4-hydroxy studies show it may directly damage DNA and cause mutations. So this is what we call the bad estrogen. We don't want it to break down into the 4-hydroxy. Equine estrogens like Premarin increase the 4-hydroxy. So people also who have fibroids may have an increase in 4-hydroxyestrogen. The good news is we can fix this. We can fix the pathway so it's perfect in every single patient. The science is here. So you can raise 2-hydroxyestrogen with moderate exercise, cruciferous vegetables like broccoli, Brussels sprouts, kale, cauliflower, flax, soy, kudzu, indole 3-carbinol, its breakdown product DIM, and sulforaphane. Also omega-3 fatty acids. Almost every disease process in the world after the age of 45 is inflammatory in nature, and omega-3s are great to reduce inflammation. Everything that supports methylation will raise 2-hydroxyestrogen, rosemary, turmeric, weight loss, and a higher protein diet. There are other factors that affect estrogen breakdown. Obesity is one of those. Estrogen is stored in fat cells. So helping her be an optimal weight helps with estrogen breakdown and the amount of estrogen that she has as well. Concentrations of sex hormone binding globulin tend to be decreased, then there's more available estrogen for the body to use when the patient is overweight. In fact, it's really important to measure hormones. I'm going to talk about that in just a minute because not all women lose estrogen at menopause, particularly if she's overweight. She may not lose estrogen for 5, 10, or 15 years. And of course, there's environmental estrogens. There's between 50 and 75 chemicals that imitate estrogen, pesticides, synthetic hormones fed to animals, plastics, as I mentioned, and even cosmetics. Some companies put hormones and their derivatives in cosmetics. Alcohol. This is becoming a big issue. When women metabolize alcohol, it's different than men. It's slower. And alcohol does interfere with the body's ability to detoxify estrogen and increases E2 levels, increases the risk of breast cancer. I actually could have put numerous references here. So the American Cancer Society came out this year and it suggests that women do not drink alcohol at all. Certainly anything beyond one drink is probably not a wise idea. With my family history, Do I drink? Honestly, I am a teetotaler because of my family history of breast cancer. So be aware. If she is drinking 2 drinks a day, have her cut her alcohol intake in half. Antibiotics found in food may be associated with an elevated risk of breast cancer by changing the gut flora involved in the intrahepatic circulation of estrogens. Estrogen does equal memory, literally. As you start losing estrogen, the patients come in and they say things like, oh my gosh, I can't remember how to spell the word took. I feel like I'm losing my keys. Am I getting Alzheimer's disease? New studies are showing that it's really, really important to start estrogen as the woman loses it for brain protection and heart health. Studies are showing that if you start it within a year, that's the best. Within 5 years is still optimal. However, does that mean if someone was 90 and they had never been on hormones and they came in to see us, would you still start hormones if they were a candidate? I would. The oldest patient in my practice that I started on hormones that had not been on them, she was 96 years of age. It still has brain and heart protection, just not as much as if you had started it earlier. Estrogen does increase blood flow, protects the neuron, increases neurotransmitters. It keeps the blood-brain barrier working. It increases sensitivity to nerve growth factor, and again, decreases beta amyloid peptides. It's a natural antioxidant. It increases memory, speed, and dexterity. It increases the availability of acetylcholine, the main neurotransmitter of memory. It boosts the NMDA receptors by 30%, decreases distractibility, and turns on the progesterone receptors. So, what does the medical literature say when it comes to heart health? 2019 study. Reports have correlated the use of estrogen for looking at the treatment of menopausal symptoms with beneficial effects on the cardiovascular system. The prospective randomized women's health initiative and the early versus late intervention trial showed that starting menopausal hormonal treatment within 5 to 10 years of menopause is fundamental to the success of estrogen's cardioprotection in postmenopausal women without adverse side effects. In fact, estrogen is so important for heart and brain. The American Gynecological Society now is recommending that in women that have had hormonally related breast cancer, if they had no reoccurrence for 20 years, they be placed on hormones that are natural. Estrogen deficiency has been suggested to be a state of accelerated aging. So what do we do with estrogen? It's always put on the skin. Put it on an area of fat cells, it gets better absorption. So when you apply it transdermally, have the patient put it on the thigh. It doesn't matter what she weighs. Women are designed to have children, so there's more fat cells in the thigh, even if she weighs 90. Have her rotate sites so she does not get a depot effect and rub in for 2 minutes. The use of estrogen transdermally, in stark contrast orally, has been linked to a lower risk of deep vein thrombosis, cholecystitis, osteoporosis, and stroke. Miss 2020 Stat Pearls. In fact, estrogen given by mouth is really problematic. I don't prescribe it. It can drive up blood pressure. It increases triglycerides, increases acetone, causes gallstones, elevates liver enzymes. It can increase sex hormone binding globulin, which lowers testosterone, interrupts tryptophan metabolization, and consequently serotonin metabolization. This is the big one that seems to get my patients. Estrogen by mouth lowers growth hormone. So then it's easier for them to remember, because that's the hormone that keeps you young, to put the estrogen on the skin. Estrogen by mouth does have prothrombotic effects. It does not on the skin. There's 3 medical trials showing that estrogen transdermally is not prothrombotic. Estrogen by mouth increases C-reactive protein, an inflammatory marker, and it increases carb cravings. In this 2019 study from the British Medical Journal, It compared no hormonal therapy and the use of oral conjugated equine estrogens or oral estradiol. There was an excess risk for venous thrombosis. They did not see this in transdermally applied estradiol, most commonly used as a patch in this study. So again, we have a compounded, so we can combine together E2 and E3 transdermally, and we can have the patient have the perfect personalized hormonal approach for them. In this 2013 study, researchers estimated that over the past decade, between 18,600 to 91,600 postmenopausal women, so a really big trial, ages 50 to 59 years old, who had a hysterectomy may have died prematurely because they did not take estrogen. Another study, which was a meta-analysis for 27 published studies, it showed a 28% reduction in mortality in menopausal women under age 60 who used hormone replacement therapy, and the participants also had an improved quality of life. Designer estrogens do not do the same thing. They don't balance. 2017, a study looked at coronary artery calcium scanning between 1998 and 2012. HRT results in lower arteriosclerosis and improved survival for all age groups and for all levels of coronary calcium. Another study, the consequences of hypoestrogenic duration in women's lives were poorly understood. The study of women across the nation suggests its magnitude is much greater than we ever knew. It proposes that the healthy user bias was a result of surgical treatment, and many gynecological maladies followed by pharmacological and physiological doses of estrogen to optimize patients' quality of life is in order. The past decade of research has begun to demonstrate the role that estrogen plays in homeostasis. So estrogen equals memory, helps prevent heart disease, has really 400 functions in the body, but it must balance with progesterone. It's all about balance. Symptoms of progesterone loss, anxiety, depression, irritability, mood swings, insomnia, pain and inflammation, bone loss, excessive cycling, hypersensitivity, nervousness, migraine headaches before cycles if she's still cycling, weight gain, decreased libido, decreased HDL. And again, women can have low progesterone at any age. If prolactin goes up, progesterone goes down. The patient's stressed, they can have low progesterone. Antidepressants can lower progesterone. Excessive arginine consumption, sugar may be the number one reason patients have low progesterone. Saturated fat, hypothyroidism, and deficiency of vitamins A, B6, C, and zinc. A lot of times in the medical literature even, they mix up terms. Synthetic progesterone is called progestin. Natural progesterone is called progesterone. If you're talking about synthetic and natural together, so synthetic and natural together, then it's called progestogens. But be careful because the terms are not synonymous. Again, synthetic is progestins. So what are some side effects of progestins? They can increase appetite, cause weight gain, fluid retention, irritability, depression, headache, decreases energy, bloating, breast tenderness, lowers sexual interest. Patients can have acne, hair loss, nausea, insomnia. It does interfere with the body's own production of progesterone. It does not balance estrogen. It remains in the body longer. Synthetic hormones remain on receptor sites for 6 months. Natural hormones remain on receptor sites for 90 days. The last one here is the reason why I don't prescribe progestins. They can cause spasm of coronary arteries. I have several patients in my practice who've had a major problem with stroke and with acute MI under the age of 40 that were on progestins. Progestins increase breast cell replication and growth due to the stimulation of estrogen receptors by progestins. So, yes, there's enough in the medical literature now to say that you need to have natural progesterone. Progestins do increase the risk of breast cancer. Again, more than one study and from very conservative medical journals. From JAMA 2010, estrogen plus progestin increases breast cancer incidence, with cancers more commonly node positive. Breast cancer mortality also appears to be increased with combined estrogen plus progestin use. Progestins can stop the protective effects that estrogen has on the heart. They can make the symptoms of progesterone loss worse, increase LDL, decrease HDL. They protect the uterus, but not the breast, from cancer, and it counters many of the positive effects that estrogen has on serotonin. Estrogen plus progestin does not confer cardiac protection and may increase the risk of coronary heart disease among generally healthy postmenopausal women, particularly during the first year after initiation of hormonal use. So, in this study from the New England Journal of Medicine, progestins should not be prescribed for the prevention of cardiovascular disease. Natural progesterone is different. It does balance estrogen. It leaves the body quickly. It improves sleep. It has a wonderful calming effect, lowers blood pressure, helps the body use and eliminates fats, lowers cholesterol, increases scalp hair, helps balance fluids in the cells, increases the beneficial effects of estrogen on blood vessels, increases metabolic rate. It's a natural diuretic, natural antidepressant, and anti-inflammatory. It stimulates the production of new bone. It enhances the action of thyroid, improves libido, helps restore proper cell oxygen levels, induces conversion of E1 to the inactive E1S form, promotes Th2 immunity. It's neuroprotective and it promotes myelination. Several studies. Natural progesterone effects not seen with progestins. Studies have shown that progesterone does not induce estrogen-stimulated breast cell proliferation. So again, are there enough studies to say that we need natural hormones? There are a myriad of them, and even more. Natural progesterone has been shown to decrease the risk of developing breast cancer. This study looked at 80,000 postmenopausal women for 8 years using different kinds of hormone replacement. It found that women who used estrogen in combination with synthetic progestin had a 69% increased risk of developing breast cancer when compared to women who never took hormone replacement. Women who used progesterone in combination with estrogen had no increased risk in developing breast cancer compared to women that did not use HRT. They also had a decreased risk in developing breast cancer compared to women that used progestin. Another study, same researchers. They found a 40% increased risk of developing breast cancer in women who used estrogen with progestin. In women who used estrogen combined with progesterone, there was a trend toward a decreased risk of developing breast cancer. The ratio does matter. If you have prolonged use of progesterone without adequate estrogen, it can cause anything on this page. So lipids don't balance, insulin resistance goes up, fatigue, decreased libido, and an increase in fat storage. How about if you have too much progesterone, even if you have enough estrogen? That's not good either. It really is all about balance. Because if you have too much progesterone, even with adequate estrogen, it elevates cortisol, increases insulin resistance, increases appetite, carb cravings, relaxes the smooth muscles of the gut, can cause constipation, can cause incontinence, lowers growth hormone, can cause the ligaments to relax, and the patient can have backaches, leg aches, achy hips, and it compromises the immune system. Adrenaline interacts with progesterone. So adrenaline surges that occur with stress can block progesterone receptor sites. So if you don't also look at cortisol in this hormonal balance, even if you give her progesterone or she makes her own progesterone, the receptor sites may be blocked and it will not take advantage of the progesterone that is there. So we do want to have it compounded. From Spearoff's work presented at the North American Menopause Society, he suggested that progesterone should be PO for peri and postmenopausal women and PO or a cream for younger patients. This is kind of a change. We do know certainly that for women who have insomnia, the progesterone should be PO because then it crosses the blood-brain barrier, hits the GABA receptor sites, and has a nice calming effect. So certainly with insomnia, it has to be PO. I really have changed my own personal practice. I now give peri and postmenopausal women, insomnia or not, PO progesterone. My younger patients with PCOS, PMS, etc., I usually use progesterone transdermally. In this study, it measured blood levels of progesterone in 6,000 women that were premenopausal. Women with the highest levels of progesterone who had regular cycles had an 88% reduction in the risk of developing breast cancer. Obviously, we could go on and on. Another study, 1,000 women. These are not small trials. They were looked at for 30 years who had treatment for infertility. The trial was done to look at subsequent breast cancer risk. Women who were deficient in progesterone had 5.4 times increased risk of developing premenopausal breast cancer, and they were 10 times as likely to die from any cancer. Part of this hormonal balance is testosterone. Now, what happens perimenopausally and menopausally? 1/2 of women never lose testosterone in their entire life. It stays normal. I am actually one of those women. I will be 67 this summer. I still have very normal testosterone, so I'm not going to lose it. Of the remaining 1/2, half of those end up with high testosterone, which is problematic, and the other half end up with low testosterone. But testosterone is important. It increases sexual interest. It increases a sense of emotional well-being, increases muscle mass and strength, helps maintain memory, helps the skin from sagging, decreases excess body fat, helps maintain bone strength. It has a tricyclic effect and helps with pain control. So symptoms of testosterone loss, yes, decreased sexual interest, but she can also have muscle wasting, weight gain, fatigue, low self-esteem, decreased HDL, thin, dry skin with poor elasticity, thinning and dry hair, droopy eyelids, sagging cheeks, thin lips, anxiety, and the memory is not as sharp if she does not have testosterone. A woman can have low testosterone at any age. All these reasons can cause it. In fact, when women deliver, their hormones don't always reset themselves correctly. Birth control pills lower testosterone, as do statin drugs. So we do replace testosterone if it's low. It should be on the skin. We don't want to use oral. The methyltestosterone, there is an increase in cancer of the liver. We usually apply it to the thigh. Very important to rotate sites, or she will grow hair. She keeps putting it in the same place all the time, and rub in for 2 minutes. Eventually, I combine together the estrogen and testosterone into one cream. I'd like to suggest to you that you don't do that initially. And the reason for that is if you keep them as 2 separate creams, and if someone has a side effect, let's say they got acne or facial hair from testosterone, you can just change the dosage without them having to throw it away. Later on, I do put them together in one cream. Without estrogen, testosterone cannot attach to brain receptors. Now, this last one is really important. I see some people giving testosterone to women who have low estrogen, like women with breast cancer that's hormonally related. If you give testosterone alone and the woman does not have adequate estrogen for any reason, it increases plaque formation and absolutely will increase her risk of heart disease. Again, it is all about balance. Can you raise testosterone without giving testosterone? Yes, exercise is the best way. Lowering stress, zinc is really important. You need that to make testosterone. Increasing protein in the diet, decreasing caloric intake, the amino acids arginine, leucine, glutamine, getting enough sleep, losing weight, and again, reducing stress can all raise testosterone. These are symptoms of elevated testosterone, PCOS, or again, perimenopause or menopause. This can happen, and they're not great symptoms. It can cause anxiety and depression, fatigue, hypo or hyperglycemia, salt and sugar cravings, agitation and anger, facial hair, acne, weight gain, hair loss or hair in places you don't want it. And again, there is an increased risk in heart disease. There's at least 14 herbs that lower testosterone if it's high. Saw palmetto is the most commonly used, 250 milligrams BID. If the patient already has insulin resistance, you may consider metformin. Remember, metformin depletes the body of coenzyme Q10 and B vitamins, so make sure those are replenished. We used to use a lot of spironolactone, not so much anymore. In fact, honestly, I don't think I have any patients on spironolactone. Measurement of testosterone levels in women. Androgens, both in excess and depleted states, have been implicated in female reproductive health disorders. This study revealed the commercially available androgen assays have significant limitations in the female population. And this is because they were looking at blood studies. So let's stop a second and talk about measurement. Can you measure hormones by serum? You can. I don't tend to do that because cortisol has to be measured by saliva. There are 6 medical trials showing not for Addison's or Cushing's, but for hormone replacement and other reasons to look at cortisol. The best way to look at it is salivary testing. So yes, there are functional medicine laboratories that do salivary testing of cortisol, but even LabCorp and Quest do as well. It is the gold standard. Any hormones that are applied on the skin have to be measured by saliva because it does not show up in the serum. We are about to publish the results of our trial showing this. So again, estrogen and testosterone are put on the skin, so you cannot measure by serum. You have to measure by saliva. It's important to look at estrogen breakdown or metabolization, which is a urine study. But please don't dose off of urine. It's a metabolite. I don't think anybody here today would dose thyroid off of a thyroid metabolite. It's a hormone. These are hormones. You want to dose off of looking at the actual bioavailable hormone itself, which would be saliva testing. It's very cost effective. It's actually less expensive than blood work is to do. So saliva testing is what the science is now showing. So when I see patients, I see them, send them home with a saliva testing kit, bring them back, prescribe the hormones, recheck them in 90 days, because it takes 90 days for the hormones to all balance themselves. And then I recheck them every 6 months. We used to look at once a year. From personal experience, that's not enough. Every 6 months is important. Looking at sex hormone binding globulin is important as well. How about the adrenals? They are part of the hormonal symphony, DHEA and cortisol. DHEA is a hormone, as I said, made by the adrenals, but it's also made in the brain and skin. It does decline with age, starting, believe it or not, in the late 20s. By the age of 70, the body may only make 1/4 the amount of DHEA it made earlier. Stress can also change it. DHEA has a lot of functions. It lowers cholesterol. It decreases the formation of fatty deposits. It prevents blood clots, increases bone growth, promotes weight loss, increases brain function, increases lean body mass, great for a sense of well-being, helps the patient deal with stress. It supports the immune system. And certainly in this COVID world, huge to support the immune system, helps the body repair itself and maintain tissues, decreases allergic responses, and lowers triglycerides. This study reviewed the functions of DHEA, It exerts an immunomodulatory action. It increases the number of monocytes, T cells. It has physical and psychological improvement. DHEA restores helps with total cholesterol, well-being. It is even anti-inflammatory. It modulates cardiovascular signaling pathways. Again, a lot for it to do. It also improves sexual satisfaction, fertility, and age-related vaginal atrophy, and it attenuates T helper to allergic inflammation as well. You can have low DHEA at any age, and patients that smoke usually have low DHEA. Nicotine inhibits the production of 11-beta hydroxylase, which is needed to make DHEA. So when you replace DHEA, you get all these great things. It does improve the quality of life. It gives you energy, improves sleep, sense of well-being. It's great for your memory, helps insulin sensitivity, decreases joint soreness. Large doses of DHEA are used for autoimmune diseases. Smaller doses are used for hormonal balance. Women are more sensitive to the effects of DHEA than men, so until the age of 65 to 70, we use baby doses. I commonly start with 2.5 to 3.5 milligrams. A recent study showed that patients that use statin drugs tend to have lower sex hormone binding globulin and lower DHEA levels than controls. You don't want to have too much DHEA either prescribed that way, the patient taking it without a prescription, or because they're stressed. It can cause any of these symptoms, which I call going postal. And of course, it balances with cortisol. I found these great dog pictures from this book called Dog Play, and the quips actually came from the book. I love animals. I love cats and dogs. I mean, look at these eyes. I mean, doesn't that just calm you? He's so cute. Don't microanalyze every nice breeze that comes your way. In other words, the hypervigilant patient, you will have a really hard time normalizing their cortisol. Cortisol is the only hormone in the body that goes up with age. It's made by the adrenals, and this crazy 365, 24/70 COVID society, overbooking, can't eat in a restaurant, cannot eat in a restaurant, it does cause people to be stressed. I love this poem from the poet Carl Sandburg. Time is the coin of your life. It is the only coin you have. Only you can determine how it will be spent. Be careful lest you let other people spend it for you. Great looking dog. Life isn't a busy contest. It's not. Cortisol balances blood sugar. It helps with weight control, the immune response, bone turnover, stress reactions, sleep, protein synthesis. It's great for the memory when it's normal. When it's not, it causes issues with memory and focus. It's anti-inflammatory and balances the other hormones. Yes, stress elevates cortisol. Obviously, Cushing's disease does, but depression, high progestin intake, sodium depletion, high prolactin, inflammation, and obesity can drive up cortisol. Cortisol can be too low. Chronic stress will cause that. Addison's disease, opioid use, chronic marijuana use can cause cortisol to be too low. Accutane and corticoid use. So, when the patient's first stressed, cortisol goes up. When they've been stressed for a long time, the body still makes cortisol because it has to. You have to have cortisol to stay alive. You die in 7 days if you don't have it. So if you go back and remember the steroidogenic pathway from school, remember that pregnenolone is made from cholesterol, and pregnenolone will directly make cortisol in order for the patient to stay alive. But pregnenolone is the hormone of memory. The patient stays stressed at any age, 24, 54, 84. If they stay stressed, the body will lower pregnenolone so it will make cortisol for the patient to stay healthy. One study suggested that as many as 75 to 90% of visits to primary care doctors are stress related. And chronic stress has been shown to contribute to accelerated aging and premature death. Another study revealed that chronic stress accelerated the aging process and was associated with shortened telomeres. Another great picture. Consider fresh air God's Prozac. Getting out and about is helpful. So what happens if cortisol stays high? You have a compromised immune system. How does that happen? It decreases the release of antibodies. It causes an inhibition in the proliferation of T cells, an increase in inflammatory cytokines. It inhibits the release of some interleukins. You have latent virus activation, and there's a shift from Th1 to 2H2 cytokine expression. So it does compromise the immune system if you stay stressed. It also causes bone loss, fatigue, irritability, and sugar cravings. It drives up cholesterol, blood sugar, blood pressure, triglycerides, binge eating, night sweats, low energy, memories not as sharp at any age, shakiness between meals, and confusion are all consequences of elevated cortisol. So is blood sugar becoming abnormal, an increase in infections, thin skin, easy bruising, muscle weakness, weight gain around the middle, sleep disturbances, impaired hepatic conversion of T4 to T3, and it does favor the development of leaky gut syndrome if the patient stays stressed. So abnormal cortisol levels have been associated with many disease processes in the traditional medical literature. When cortisol is too high, that's hyperadrenalism. When it's too low, that's hypoadrenalism. So what are symptoms of hypoadrenalism? Fatigue, low blood pressure, sensitivity to light, insomnia, digestive problems, emotional imbalances and lack of motivation, hypo and hyperglycemia. The patient tends not to have good sexual interest. The immune system is compromised, lack of stamina, emotional paralysis, poor wound healing, alcohol and drug addiction, allergies. The patient can have unresponsive hypothyroidism. In other words, you give the patient thyroid hormone and it doesn't tend to work very well. These patients feel overwhelmed. So how does a patient get too low of cortisol beside long-term stress? Nutritional deficiencies, dysbiosis, chronic inflammation, chronic pain can cause this. Toxin exposures, overly aggressive exercise without replenishing nutrients, long-term hypoglycemia, poor sleep hygiene, depression, and severe allergies. The hormones really are a web. If cortisol is increased, it decreases the making of progesterone and its activity. Cortisol competes with progesterone for common receptor sites. When cortisol is elevated, thyroid hormone is more bound and less active, and decreased estradiol actually is a stressor to the body. Clinical pearl. It's very important to fix cortisol first, at least begin working on it for 6 to 8 weeks before you go back and deal with hypothyroidism if there is hypothyroidism present. So what do? How do you treat hyper or hypoadrenalism? You start out the same: stress reduction techniques, prayer, meditation, Tai Chi, yoga, Qigong, exercise, massage, breathing techniques, acupuncture. Replace DHEA if it's low, but make sure you have adrenal support on board. If you just give the patient DHEA and cortisol is abnormal, too high or too low, and you don't also support the adrenal glands, when you go back and remeasure DHEA, it will be even lower. Adaptogenic herbs. Again, if cortisol is too high or too low, rhodiola, ginseng, ashwagandha. If the patient's stressed and wired, calming herbs are important. And if cortisol is high in the evening, then you can add phosphatidylserine, 300 milligrams, which can be taken at any time of the day. I do put the patient on a multivitamin. All these nutrients are needed by the adrenal gland to work well. So everything is the same so far for hypo or hyperadrenalism. But for low cortisol, if you've done all these things and cortisol remains low, then we take people off of adaptogenic herbs and instead add adrenal extract. You can add the herb licorice, not the candy, the herb licorice. Do not give it to people if they have hypertension. If they develop hypertension while taking it, then take them off of licorice. The last resort for hypoadrenalism is Cortef. Please do not start with this. The medical board will not look favorably on this. You have to do everything else first. You only use it for 6 to 9 months. You wean the patient off and keep the adrenal extracts there during the weaning process. And lastly, pregnenolone. It is the mother hormone. The conductor of the hormonal symphony is thyroid, so it does regulate all this. But pregnenolone, the hormone of memory, does make estrogen, progesterone, testosterone, DHEA, and cortisol. Sometimes cardiologists forget. If you get the cholesterol too low, below 140, then it's really hard for the body to make pregnenolone. I had a dentist who came into my practice at 42. He said he wanted to quit practicing. I looked at him and I said, my gosh, you're kind of young. He goes, oh, I don't have dexterity. I don't have energy. And then he handed me his blood work. His doctor had written a smiley face by his total cholesterol of 107. I looked at him and I said, quit taking your statin drug. They've got your cholesterol way too low. There's other things we can do if your cholesterol is high, etc. But right now it's too low. Then you're not going to make pregnenolone to make your other hormones. Within 9 months, he felt great. He's still practicing dentistry 20 years later. He's still my patient. And it's really fascinating. He didn't make all these other hormones because pregnenolone was so low because they got his total cholesterol too low. So keep that in mind. And pregnenolone does go down with age. It is a serum test, and you do have to measure. Again, I will be 67 in July. I didn't start taking pregnenolone until 6 weeks ago. So I didn't need it until now. Some patients need it younger. If really young patients have low pregnenolone, then what do? Fix the cause of the problem, which is stress. Pregnenolone, again, is a serum test. It needs to be at least 50 to maintain memory. Pregnenolone regulates the balance between excitation and inhibition in the nervous system. It increases resistance to stress. It improves energy, both physically and mentally. It enhances nerve transmission and memory, reduces pain and inflammation, and it blocks the production of acid-forming compounds. It modulates GABA, helps to repair nerve damage, promotes mood elevation, improves sleep, enhances acetylcholine transmission, and modulates the NMDA receptors. Pregnenolone can be low at any age due to all these reasons, including eating too much saturated fats and trans fats. So symptoms of pregnenolone deficiency: arthritis, depression, fatigue, inability to deal with stress, insomnia, lack of focus, and cognitive decline. Pregnenolone in the medical literature has been used to treat many different things, including these autoimmune diseases. Pregnenolone may protect the brain from cannabis intoxication. Thought that was interesting. Use it in caution with people with seizures. You can use it. It can lower the seizure threshold, so don't start with big doses for anybody. I usually start with 10 milligrams. And I do have 6 patients in my personal practice that can't even tolerate taking 10 milligrams. I have a couple of people on 1 milligram, 5 milligrams. That's the great thing about compounding and the great thing about personalized medicine. You can customize it to each patient. Elevated pregnenolone levels can cause acne, drowsiness, muscle aches and pains, fluid retention, headache, heart racing, insomnia due to overstimulation. So we usually have people take it in the morning, irritability, anger, anxiety. And yes, I have seen all of those. We talked about measurement of hormones. So in summary, all the hormones in the body are designed to work together. If one is altered or deficient, it will affect the action of all the other hormones. Consequently, as you have seen today, it's very important to have it compounded so you have personalized care. You can adjust it accordingly each and every time. It is important to use bioidentical for all the reasons we have discussed. It is all about balance. Start low, go slow. One size does not fit all.
Thank you for listening to the webinar today on What You Must Know About Women's Hormones by Dr. Pam Smith. If you're interested in obtaining her book, you can get it at the link here. We hope you got some great takeaway information from what you learned today and that you learned something new. We designed the Innovation Institute to provide you with the tools and education that you need to grow your practice and increase your knowledge base. My name is Tara Thompson, a pharmacist at the Innovation Institute, and we encourage you to sign up for Dr. Smith's other webinars by visiting our website at www.innovationcompounding.com. There you can also sign up to view previous webinars in the library or sign up for future ones by Dr. Smith. As always, we are here for your questions and feedback, so please reach out to us. Thank you for listening today and be well.